Welcome everyone to this week's Mountain West ATC Echo. Really happy to see you all and happy to welcome back a familiar face to Echo, Dr. Julie Dombrowski. I think many of you know and have interacted with, probably called for consults and have seen talk before. I asked Julie to give this talk after seeing her present some of this on sort of current best practices in STI care and treatment and also some controversies. I thought it was fascinating, and Julie, I thank you for doing this.
Thank you very much. It's great to see all of you. Good afternoon. I am going to give a rapid fire STI update today and hopefully still leave a little bit of time for questions. My disclosures are shown here. All right, I'm going to briefly review some released 2017 data that came out last week, then describe 3 things that all HIV clinicians should be doing related to STDs. I'm going to mention 2 standards of practice here in Seattle that differ from the guidelines for your consideration, and briefly review 2 clinical controversies in STD. These numbers came out last week during the STD Prevention Conference. They're preliminary surveillance data from CDC, and essentially what they show is that for the 5th year in a row, we are having major increases in all 3 bacterial STDs. Syphilis up 31% over a 5-year period, gonorrhea 67%, and syphilis 76%. As many of you know, these increases are primarily among men who have sex with men, and to a lesser extent also among heterosexuals, gonorrhea in particular. And of course, it's not just these infections themselves, but the morbidity they cause that is a major cause for concern. Along with syphilis case increases, we are seeing an increase in complicated syphilis, ocular syphilis, and neurosyphilis, which can cause permanent defects, as well as increases in congenital syphilis. And of course, we have perennial concerns about developing antimicrobial resistance among Neisseria gonorrhea. So what should we as clinicians be doing in the context of this major STI increase? 3 things I want to highlight today. First, extragenital screening in MSM. All sexually active men who have sex with men, as well as transgender or non-binary persons who have sex with men, should be screening at least once per year. It's really important to check the rectal and pharyngeal sites because you will miss the majority of STDs among MSM if you just check the urine. The CDC guidelines recommend more frequent testing for men at higher risk and don't specify that. What we recommend here locally is Q3-month screening if patients have any of the following risk factors: bacterial STD in the past year, methamphetamine or popper use, 10 or sex partners, or condomless anal intercourse with HIV serodiscordant or unknown partners, as well as those taking PrEP. Those are science-based criteria, but I would say if they're too hard to remember, just screen all MSM every 3 months at exposed sites. Self-testing is an excellent option. This has really transformed our practice of STD screening here at Madison. What's shown on the screen are 2 of the original posters to prompt patients and instruct them on how to collect rectal swabs and oropharyngeal swabs. There are now newer posters that have more diverse skin colors, and there's one for women, and they are in Spanish, and the anus is correctly anatomically located on the new ones. So if you would like to talk with us about how to implement this in your clinic or get these posters, feel free to email Amy Radford, which you can see in the bottom, her email address at the bottom of the slide. All right. Number 2, treat STD contacts empirically. This is a really important one that is often missed in HIV clinics and primary care clinics. When a patient comes in and says they know because a sex partner told them or they got a call from the health department that they've had sex with somebody who has chlamydia or gonorrhea or syphilis, treat them right then. Don't wait for the results of testing. And there are a couple of reasons why this is recommended. First, there's a high pretest probability that that test is going to be positive. Unlike HIV, bacterial STDs are extremely transmissible. With one sex event, the estimated transmissibility for syphilis is 30%. For gonorrhea, it's probably closer to 50%. Second, those who have had contact to syphilis, your test will not tell you reliably whether or not they have syphilis, because about 15% of patients in primary, and probably more in the stage prior to primary, will have negative serologic tests. So if someone knows they've had contact to syphilis, they need penicillin treatment as well as testing. Third, there is a public health imperative to prevent ongoing transmission. So please don't just test and send out patients who come in and tell you they know they've had contact to STDs. Number 3, please screen for and rapidly evaluate and treat complicated syphilis. This is a big topic in and of itself that I'm sure you visited at some point on Echo, but I would say it's crucial for all of us when we diagnose a patient with syphilis to ask screening questions about neurosyphilis, otosyphilis, and ocular syphilis. The key questions include, have you had a change in vision or photophobia, a change in hearing, new or changed tinnitus, and difficulty walking? The latter one was from a recent study conducted by Christina Mara. There continues to be a big debate about who with syphilis should get an LP, but there's no debate that patients with symptoms of neurosyphilis or potential neurosyphilis should get an LP. So an LP is the key part. It's also important to remember that patients with ocular syphilis and otosyphilis can have negative LPs. So patients with vision symptoms should ideally get an urgent ophthalmologic eval, and patients with a hearing symptom should ideally get an urgent audiologic eval. But if that is not possible, I would recommend empirically treating for neurosyphilis patients who have true new vision or hearing changes in the context of a new syphilis diagnosis. Importantly, as we're thinking about complicated syphilis, we should not delay treatment while we wait for the evaluation. And when you have a patient and you're planning the evaluation, if it can't be done the same day, give bicillin at that visit. Okay, so now let's move up the level of controversy just a bit to talk about two local standards of practice here that differ from guidelines. First, we do recommend in the Madison Clinic testing HIV-positive MSM for syphilis with every blood draw. This comes from practices and some evidence in both Australia and Baltimore here in the US. The Australians have actually a national gay men's syphilis action plan, and a key part of that is testing for syphilis among HIV-positive men MSM with every blood draw. When that was put into place in 2007, they increased the median number of tests from 1 to 2 per man, so it certainly increased testing. And of the syphilis cases that were found, many, many more were asymptomatic, which suggested that this additional screening was truly finding cases that wouldn't have been found through clinically driven testing. So although it's not clear that this is an excellent case-finding mechanism, it's easy to do and recommended. Something we do here is try to send syphilis for sexually active MSM with every blood draw. Second, treat rectal chlamydia with doxycycline. The CDC guidelines do still recommend both azithromycin 1 dose or a week of doxy as equal first-line treatments. And clinicians generally tend to prefer azithromycin since it's an easy one-time treatment. However, there is an abundance now of retrospective data suggesting that doxycycline is substantially more effective than azithromycin for rectal chlamydia. A pooled efficacy estimated the efficacy of azithromycin at 83% and doxycycline at near 100. The challenge is these are all retrospective data, so we don't know for sure. There is an ongoing randomized controlled trial, but in the meantime, our standard of care in the STD clinic and in Madison Clinic is to treat rectal chlamydia with a week of doxycycline when feasible and acceptable to the patient. Okay, and lastly, two clinical controversies that I want to cover you may have thought about or may have opinions on. First is, should we be doing extragenital screening in women? I just described and re-emphasized the case for extragenital screening in MSM. And of course, women also get pharyngeal and rectal GC and CT. However, isolated extragenital infections, that is, those women who have rectal or pharyngeal infection but do not have urogenital infection, isolated infections are less common in women than in MSM. However, they're frequent enough to repeatedly raise the question of should we be screening women also at the rectum and throat. Summary of 14 studies suggested that the prevalence was around 2%. There was another study at the STD conference just last week that found a much higher prevalence of women in Louisiana. So this is a changing target. However, interestingly, rectal chlamydia is not associated with anal sex in women. Unlike in MSM, where it's very clear, in women, where there have been studies of women who report having anal sex and those who don't, they have equal prevalences of rectal chlamydia. And there's been enough of that now that a meta-analysis definitively said rectal chlamydia is not associated with anal sex. And that's an interesting topic because we don't know exactly why that is, but it probably has two major hypotheses. One is that we may acquire chlamydia, like other animals do, through the oral tract that then sets up shop in the rectum and stays there. The second possibility is that women obtain rectal infection through auto-inoculation, and then the rectal infection lasts longer than the urogenital infection? We don't really know. So the question is really not just, is it there? Yes. But what is the public health and the clinical significance of extragenital infections in women? And that's what we don't really know. And the strongest case for screening would be if we could demonstrate that rectal infection is associated with urogenital infection in women, that they either get it from the rectum or that having it in the rectum increases the risk of treatment failure. So if rectal infection is contributing to urogenital chlamydia infection, and if azithromycin is inferior to doxycycline for the treatment of rectal CT, as I just showed you earlier, then we would expect differential failure with azithromycin versus doxycycline for the treatment of urogenital chlamydia in women. And there is some evidence of that. Christine Kozrapor here at the UW did an analysis of all Washington statewide data and showed that indeed there was a significantly different, persistent, and recurrent CT rate, a proxy for treatment failure, among women with urogenital chlamydia who were treated with azithromycin versus doxycycline. 63% of the infections received azithromycin, but 80% of the failures received azithromycin. So this is not definitive evidence. The jury is out. It's not recommended, but certainly that's one controversial topic. Controversy number 2 is doxycycline post-exposure prophylaxis. So the idea here is that patients who are at increased risk for STDs take 1 dose of doxycycline, 200 milligrams, a double dose, I should say, 24 to 72 hours after having sex. And the idea here is to prevent syphilis or chlamydia, to a lesser extent gonorrhea. This was studied in a randomized controlled trial in the IPERGAY study, which is a study of on-demand PrEP among French MSM. It did indeed prevent syphilis and chlamydia. It decreased the time to first STI with no evidence of behavioral risk compensation and low discontinuation rates. However, this is a small study. It's very preliminary data. There are big potential downsides of using doxycycline PEP that we don't yet know enough about, namely antimicrobial resistance, not just in our STI pathogens, but also other areas of the human microbiome. And number 2, doxycycline, although generally safe, if we vastly expand the use, there are some adverse effects that we need to consider. So it's not yet clear how these balance out, and considering what morbidity we're trying to avert with this is also very important. So again, jury's out, studies are being done. My opinion is in rare individual cases, it may make sense, but not as a general policy or practice. However, I do want to mention that patients are really interested in DoxyPEP. There was a Grindr survey, so that's a geospatial networking app that probably most of you have heard of, but if not, that's one way many MSM find sex partners. There was a survey of 1,300 men in 6 U.S. cities asking about DoxyPEP, and 85 to 90% of men expressed interest in it. We also did some quick surveys here in Seattle among our PrEP patients and in San Francisco, and again, 90% of HIV negative patients were interested in DoxyPEP. And in San Francisco, it's already being distributed in the community and through various online mechanisms. So I would say, again, the science is yet to be determined whether this is really a good approach. But I do think it's worth noting that patients may get ahead of us as prescribers on this one, and just to keep that on your radar. So thank you very much for your patience during my extremely rapid fire STI update. I do want to remind you there are some excellent resources available. There is the PTC Clinical Consultation Network where you can put in a question and your time frame in which you need an answer, and it will be sent to one of us. And second is the National STD Curriculum, a really excellent resource for education and updates either for you or others you're working with. So please keep those in mind.